So today we're going to talk about the prostate. And many of you probably heard of the prostate, but you may not know what the prostate is. And the prostate is a male sexual gland. And it sits deep within the pelvis. Again, only men have a prostate. And the purpose of the prostate is to make seminal fluid. So when a man has sex and ejaculates, he ejaculates the seminal fluid, which is made by the prostate. Inside the seminal fluid swim the sperm, which is made by your testicles. And so the seminal fluid provides nutrients to the sperm. The prostate sits below the bladder, and the prostate really looks like a donut. So you can see here that in the middle of the prostate, you have a tube. And so when you urinate, the urine goes through the middle of the prostate and comes out the urethra. So two things happen when we age. First of all, we can get prostate cancer, and I'll talk about that later. The second thing is our prostate can get bigger. And it has a lot to do with the hormone changes in our body as we get older, and also has to do with family history. So if your father has a big prostate, you probably have a big prostate also. Some of the symptoms that you have with an enlarged prostate are called LUTs, or lower urinary tract symptoms. And these are things like slow stream, hesitancy. In other words, it takes a little while for the urine to come out. You have to strain to urinate. You don't get all the urine out. You have frequency, urgency. You wake up at nighttime to go bathroom. So these are the symptoms of BPH, or benign prostatic hypertrophy. If you have very mild BPH symptoms, maybe non-pharmaceutical treatments and lifestyle management may be enough to help you. And so here is Larry King. He's advertising these drugs. These are non-pharmaceuticals, things like saw palmetto, pyrigium. Saw palmetto was actually something that's from the southeast of the United States. It's a berry, and the Indians used to take these berries and make tea with it and drink it, and that would help with their BPH symptoms. So it's very mild, but it does help for people who have very mild BPH problems. Lifestyle management has to do with the more trying to limit how much you drink at night, so you don't have to wake up so often. But if that is not enough, we can give you medications. So people who have moderate BPH symptoms may try medications. There are basically three types of medicines that we use for BPH. Alpha blockers. The common medications are tamsulosin, silodosin, terazosin, doxazosin. So you may have heard of these medications, and they cause the smooth muscle that's around the bladder neck and the prostate to relax. And as a result, you can urinate a little bit better. Then we have 5-alpha reductase inhibitors, and this is finasteride, deuteroside. These are medications that actually shrink your prostate. So they shrink your prostate about 30%, and then if they shrink your prostate, then hopefully you can urinate better. Alpha blockers actually work a little bit better than 5-alpha reductase inhibitors. Alpha blockers, a side effect would be maybe dizziness. So sometimes one of the side effects that you may suffer from alpha blockers could be dizziness. With 5-alpha reductase inhibitors, you might have a little bit erectile dysfunction where you have trouble getting erections. Tadalafil is an erection pill. What we found with tadalafil that it does help you urinate better. And the other medicines we use for erectile dysfunction really don't do that. So tadalafil increases your cyclic GMP. This causes the muscle around your prostate and your bladder neck to relax. You can urinate better. And in addition, you'll have good erections. If medicine is not good enough, if you have very severe BPH symptoms, then we have to start talking about surgery. And the gold standard of surgery is the transurethral resection of the prostate. We call it a TURP. And this surgery works very well for patients. Patients pee very well. It has very good long-term outcomes. However, there's still a high morbidity with this surgery. So patients who have this operation may have a long time recovering. Here you see a scope. This is a resectoscope. And at the end of the resectoscope, you have this little loop that's hooked up to electricity. And so you take little shavings of the prostate over and over and over. And so if you have a prostate that looks like this, by the time you're done, it looks like this. So you can see the urethra is nice and open, and you should be able to urinate really well. The only problem with this surgery is that the recovery is very slow. And if you think about it, the mucosal lining that was inside the middle of the prostate is all gone now from shaving it off. And it takes about 3 months for it to grow back in. So that's why you have bleeding after surgery, and that's why the recovery is kind of slow. So it burns when you urinate, and you have frequency when you're urinating. It takes about 3 months for that to all go away. The other thing is you can have retrograde ejaculation. So you still have good erections after a TURP. However, when you have sex and you try to ejaculate, most of the seminal fluid goes up into the bladder and not out through the urethra. So because people don't like to get TURPs, we try to develop other kind of procedures to help you. And so one of them is the laser prostatectomy. And there's different kind of lasers we use. This one is the enucleation. And so you put a scope inside, and the laser will separate the BPH, a part of the prostate, which we call adenoma, away from the capsule. And you do this, and then you push the adenoma into the bladder, and then you do the other side, and you push it into the bladder, and then you have this nice open prostatic urethra now. The pieces that are in the bladder, we use something called a morcellator to take them out. So this surgery works very well, very little bleeding, recovery is faster, high success rate, very, very good for people who have very large prostates. You do have burning after you urinate, and sometimes it's not enough to help you urinate really well. Another type of laser is what we call a photoselective vaporization. And this is where the laser actually will vaporize the prostatic tissue. So here you see that the laser is vaporizing the tissue. It works very well, less bleeding, short recovery, high success rate. Same side effects as the other prostatectomy, where you have burning when you urinate, which is dysuria, and sometimes it's not quite enough. We have a few new minimally invasive procedures that we're doing. This one is called prostatic urethral lift, and it's a mechanical way to open up the middle of the prostate. And we don't cut any tissue, we don't vaporize any tissue. It's completely a mechanical way of doing this. And what we do is we use these small little clips to squeeze the tissue together to open the urethra. And so here is a scope that we're putting inside the urethra. And now we're going to bring it back down to the level of the prostate, compress the tissue, release a clip, and it's going to anchor at the capsule. And then we compress the tissue and release a second clip. And we do that in various areas of the prostate to open up the prostatic urethra. So you still get that big, wide open urethra that you get when you do a TURP or you do a laser prostatectomy, except this time we're not cutting any tissue, we're not vaporizing any tissue. And this tissue will gradually atrophy. That means it'll begin to shrink down on its own. Very easy to do, Patients recover very quickly. It's durable. So this is a good procedure. It's not really good for people who have huge prostates, though. So you can see that they have a nice wide open urethra that they can urinate through. And then this is water vaporization treatment. So we actually use steam to shrink the prostate. So when we use steam, the thermal energy from the steam will actually start vaporizing the prostate tissue. So here we have another scope that we put in, but this scope has a needle, and we inject steam, 9 seconds of steam, into various areas of the prostate. And the steam is able to distribute itself through the tissue. And so it can get far deep into the prostate, and then over 1 to 3 months, the prostatic tissue will begin to atrophy or shrivel up. And so then it will open up. So this is not an immediate effect. Again, it takes 3 months. It's durable, minimally invasive, and we're doing a lot of these procedures also. So there are other procedures we're doing, but one of the last ones I want to talk about is prostatic artery embolization. And this is not really done by urologists, but done by radiologists. It's very similar to a cardiac cath, where you put a needle into the femoral vein or artery. You go up to the heart or the kidney, and you do whatever you have to do. But this time we go to the prostatic artery. And we can put micro particles in the prostatic artery, and it will go into the area of the prostate, and this will cause the prostate to shrink in size. This is very, very good for very large prostates. A very high success rate. It preserves sexual function. What that really means is that you don't have retrograde ejaculation. And so the prostatic lift, the steam, they all preserve sexual function, including the prostatic artery embolization. Sometimes you can have some side effects. You can have some burning in the rectum, and you can have some burning in your urination. So these are different ways to treat patients who have BPH or an enlarged prostate. I'd like to change gear a little bit here. We're going to talk about prostate cancer now. Prostate cancer is the most common cancer in men. 1 out of 6 men in their life will develop prostate cancer. It's very analogous to breast cancer, which I know Dr. Kagehara talked about. It's the second most common cancer death in men, and there are certain risk factors to develop prostate cancer. So one is the family history of prostate cancer. So there is a genetic component to prostate cancer that we're learning more and more about. It's also related to breast cancer. So the BRCA2 gene in breast cancer is also the cancer gene for prostate cancer. Also, if you're African American, there's a higher risk. And later we'll talk about PSA screening. So PSA is the test that we currently use to screen for prostate cancer. There is some controversy about its use. If we are worried that someone may have prostate cancer, the next step is to do a biopsy of the prostate. And so we do a transrectal ultrasound-guided biopsy of the prostate. So here we see this probe. This is an ultrasound probe, and we put it into the rectum because the rectum is right next to the prostate. So just like that picture that Dr. Kamal showed you where he put a clamp, the rectum is right there. So we take advantage of that, and we can put the probe right into the rectum and see the prostate on ultrasound. And then we can guide a needle to take biopsies of the prostate tissue. What's interesting is that prostate, when you we really have a hard time identifying actually lesions in the prostate. So if you have an elevated PSA, we are concerned you may have prostate cancer. And until recently, we really were having imaging that would show you where exactly the cancer is. So when we do the ultrasound, we actually do a systematic biopsy of your prostate. We take samples from all the different areas of your prostate. And this is the way we've been doing it for 30 years. Now, PSA is a blood test. It checks for prostatic-specific antigen. And PSA is secreted by only your prostate. So if you have an elevated PSA, it can be from prostate cancer, but it can be from an enlarged prostate. It could be from some kind of infection in your prostate. So actually, when you have an elevated PSA, only 1 out of 5 will actually have cancer. We've been doing this way since the 90s. And then there is a group called the U.S. Preventative Services Task Force. And their job is to evaluate different ways that you screen for any kind of cancer, including prostate cancer. And in 2012, they gave us a rating of D, saying that we should not use PSA to screen for prostate cancer. And the reason why is, again, it's not specific for prostate cancer. We have over-detection, we have over-treatment. When you do a biopsy, you have bleeding and pain and possible infection. So they felt that it was not necessary to screen for prostate cancer. And they based it on 2 large studies that had came out about this time, where they looked at men who were screened for prostate cancer using PSA versus men who were not screened and who developed prostate cancer. And they looked at their overall survival, and they found out it was exactly the same. So they said, oh, PSA screening does not help you, and so we don't recommend it. So for many, many years, we stopped doing it. But what happened was that we started finding metastatic prostate cancer again. Over the next few years, more and more men were diagnosed with stage 4 prostate cancer and were dying from this cancer. And so we realized that probably this recommendation wasn't good. And it makes sense because you don't really change the prostate cancer. So there are patients who are going to have really bad prostate cancer, and if you don't diagnose it early, they're going to die from their cancer. And so we were missing those guys when we stopped screening. So in 2018, they had to reverse their decision and their recommendation and said that we should probably actually have a conversation with the patients, the pros and cons of PSA screening. And currently, that's what we do right now. But it brought up a good point that we need to screen more intelligently. So that's the job of the urologist, to screen more intelligently. And so we have these new things that we supplement PSA screening. We have biomarkers. Biomarkers are like urine tests, blood tests, tissue tests that we use that are more specific for prostate cancer. So we still use PSA, but if you have a high PSA, then instead of going straight to a biopsy, we use either a urine test. This is 4K is a blood test, and we also actually have a tissue test where we can say whether you're low risk or high risk for cancer and whether you need a biopsy or not. And so we've been doing this way for a number of years. Mostly now we are doing MRIs of the prostate. This is probably the predominant way we supplement PSA now. So MRIs have been around a long time, but we really haven't used MRIs too much because it didn't help us that much until there was the development of the multi-parametric MRI. So we can look at these different functional sequences using software to help us figure out if a lesion in the prostate is something to worry about. So this is a T2 weighted MRI, and it might be hard to see, but right here is a lesion. And the question is that lesion something to worry about or not? And in the past, we wouldn't know, but with multiparametrics, we're able to figure it out. So we look at something called DWI, diffusion of water index. We know that cancer tissue is more dense than regular cells. So water has a harder time going through the cancer cell versus a regular cell. We take advantage of that property, and we can see that this area lights up because over here the water is diffusing slower. This is the parent diffusion coefficient. It kind of measures the same thing, but you can see that it's darker right here. And finally, we do something called the dynamic contrast enhancement, and that is where we give contrast. And we know that cancer tissue has more blood vessels, and so it's more vascular. And so we take advantage of that property, and we can see that this lights up too. So we use all these different things, all these multi-parametrics to figure out whether someone has a suspicious lesion or not. And it goes into this complicated formula, and we come out with something called the PIRAD score, the Prostate Imaging, Reporting, and Data System. The score goes from 1 to 5. 1, you probably don't have cancer. 5, you probably have a significant cancer. And this more accurately measures our tumor volume and how aggressive the cancer would be. And so the other advantage of using an MRI is we can use the MRI picture to do the biopsy now. So we still do the transrectal ultrasound, but we can fuse the MRI picture to the ultrasound in real time using this computer software. And so we can, whenever you move the probe, the MRI picture will move with it because now it's fused, and we can actually outline the lesion that was seen on the MRI, and now we can aim for the lesion so we can actually be more accurate in our biopsies. And that kind of makes sense because if you have a lung lesion or a liver lesion or something, you just don't poke holes all over the liver to try to you just aim for the liver lesion. We couldn't do that with the prostate before, but now we can. If you have cancer, the next step is to do what we call grade and stage. And grade means looking at the quality of your cancer. Is it a slow-growing cancer? Is it a fast-growing cancer? And so fast-growing cancers are what we worry about. And we grade it from 1 to 5, 5 being a very aggressive cancer, 1 being a slow cancer. Then we look at staging. Staging is the quantity of your cancer. So you could have a low stage cancer, stage 1 or 2, where it's localized in the prostate, or you can have a stage 4 where it's spread through the whole body. So we use certain imaging to help figure that out. CAT scans, bone scans, MRI, and something new called the PSMA PET scan. And so this is localized cancer. This is metastatic or stage 4 cancer. Stage 3 is cancer that has come outside the prostate only locally. So it's broke through the capsule of the prostate, but it hasn't spread through the whole body. And once we know the grade and the stage, we're able to figure out how to treat the patient. We can start giving you choices of how to be treated. So for early stage prostate cancer, the choices would be active surveillance, surgery, radiation therapy, cryoablation, and focal therapy. Active surveillance, we just monitor you. It's based on the fact that a lot of prostate cancer is low grade and it grows slow. That's probably why these big studies showed that there was no benefit, because a lot of patients have this slow-growing prostate cancer, and we overdiagnose these, we overtreat these things. And so now, if you have one of these slow-growing prostate cancers, we don't treat it, we just watch you, and you avoid the side effects of surgery and radiation and all those things. But if you have a more aggressive prostate cancer that's localized, one of the things that we can do is a radical prostatectomy. This is done in a minimally invasive way now, mostly laparoscopic and robot assisted. Back when I was training, we used to do this open, and we would lose a lot of blood. People take a long time to recover from the surgery, but now patients lose hardly any blood at all, and they go home within the same day. But there's still side effects from the surgery. Urinary continence. We have to take the prostate out, and we have to sew the bladder back to the urethra. And so there's a period of urinary incontinence and erectile dysfunction. So there's these nerves that go and hug the prostate and go up into your penis, and that innervates the penis to cause erections. And those nerves can get injured during the surgery. Now here's a picture of the robot. And when you sit at the console, you look through these binoculars, and you can see inside the body. You can see these robotic instruments that are wristed. So they're like little hands in the body. So in our surgery, what we do is we are going to, first of all, disconnect the bladder neck away from the prostate, and then we're going to push the nerve that causes erections out of the way. And then finally, we're going to cut and disconnect the prostate from the urethra, take the prostate out, and then bring the urethra to the bladder neck and sew it back together again. And so now we can do this in a minimally invasive way using this robot. This cartoon makes it look super simple. It's a little more complicated than that. The other big way to treat higher grade, early stage prostate cancer is radiotherapy or radiation therapy. And this is where we're going to use high energy X-ray beams to kill the cancer cells. And there's different ways to do it. So the two big ways are external beam and brachytherapy. External beam means that the patient would lay on a table, the machine would be above them, it would give the beam outside the body to whatever organ, in this case the prostate, and it would burn the tissue, burn the cancer cells, kill the cancer cells. The other way you can do it is with brachytherapy. And brachytherapy means putting little seeds into your prostate and get the radiation from within, because the seeds are radioactive. When you do external beam, it works very well, but it's a 2-month process. You got to come Monday through Friday for 2 months to the cancer center and get treated. And it's very fast, 5 minutes, but you have to come quite often. If you get brachytherapy, it's a small surgery, one-time deal, and then over the next 2 months, the radiation is released from these seeds to kill the cancer. Sometimes you need a combination of both. When you do radiation, sometimes there is scatter, meaning some tissue around your prostate will get some radiation. So that's your bladder, your colon, your rectum, the nerves that cause erection. And that's why you have these side effects of urgency, frequency, urgent continence, rectal bladder bleeding, and erectile dysfunction. Both prostatectomy and radiation work about the same as far as their success rate in cancer control. And then we have different other kind of treatments that we're doing. Cryoablation means that we're going to freeze your prostate. And so by freezing it, we kill the cancer cells. That's not done too much anymore. Focal therapy is something that we're doing more and more now. We're probably going to start pretty soon at our institution. But the idea is that if you have a small area of cancer, why treat the whole prostate? Just treat the lesion. And so focal therapy will just treat the lesion and leave the rest of the prostate alone. This way you have less side effects. So that was treatment for localized prostate cancer. For people who have advanced prostate cancer, this is stage 4 cancer that's spread through the whole body. The mainstay of treatment is hormonal deprivation. In 2007, that's all we had. Testosterone is the main hormone of a male, and it is the gasoline for the prostate cancer cells. So prostate cells need testosterone to grow. And so if you take that away, then the prostate cancer cell will not grow. And so by removing your testicles, or what we call a bilateral orchiectomy, you can achieve that, and then the prostate cancer will shrink and it won't grow. However, maybe 5 to 10 years later, the cancer cells get smart and they morph and they're able to grow without the testosterone. So this is what it was like in 2007. We can use estrogens. Estrogen was a treatment to lower your testosterone, but we don't do it too much anymore, mostly because there's some significant side effects of using estrogen in men. We have LH-RH agonists, and these are shots. And so if you look at this picture here, you have the pituitary gland, and that's in the brain. That makes certain kind of hormones, including one that's called LH. And LH goes down to the testicle and tells the testicle, make testosterone. And so these are actually agonists, so that it causes you to increase your LH production in the pituitary gland. But I say it's very similar to a house where you turn all the lights on and you blow a fuse. And so we have a down regulation. And so now the pituitary gland is churning out the LH, and then the fuse kicks off, and suddenly you don't make any more LH, and that's how this one works. But for a little while, you do have a surge of testosterone, and this can be blocked by anti-androgens. So these are the different drugs that we use for anti-androgens. The one that we use most commonly is bicalutamide, and it blocks the body's ability to see testosterone. But again, what I said, this only is good for 5 to 10 years, and then the cancer changes, and then it learns how to grow even though there's no testosterone in the body. So in 2023, we have a lot more options. We still use hormonal deprivation. That's still the mainstay of treatment, but we have other things that we could supplement it with. So we have LH-RH antagonists. So a little bit different than what I was talking about before. This completely shuts down the LH without causing a surge. And one of them, Urology, is a new medication. It's a pill. All the other ones are injections. So one injection is good for about 6 months, typically, 3 to 6 months. But if you take the pill form, then you don't have to come see us all the time. Chemotherapy works now. We have different chemo agents that will help the patient. We have immunotherapy. So we can use your immune system to help fight metastatic prostate cancer. If the cancer goes into your bones, we have strontium and radium-223, which will help relieve some of the symptoms from bone pain and also help kill the cancer that's in the bone. The big thing that, the big advance actually has been these medications, which are called third generation novel anti-androgens. And this has been discovered and been used for the last 5 years or so. And it really has prolonged the control of metastatic prostate cancer in men. So before, I think I told you that, within 5 to 10 years, the prostate cancer will start to grow again. But with these medications, we found that the cancer won't grow for years and years and years after that. So some of the studies show that the cancer, even after 10 years, it still hasn't come back. And so these are fantastic new drugs that we are using quite a bit, and they really have changed the way we treat our patients. However, for those who fail, we do have newer things also. Lutetium is a very exciting new type of radiation that we're doing. I call it a smart bomb. So this lutetium is attached to something that we inject into the body, and it's attached to what we call something that goes to PSMA, which is prostate-specific membrane antigen. And then it will only go to the areas where there are prostate cancer cells, and it will kill these cancer cells. So that's why I call it a smart bomb. It doesn't go throughout the whole body and kill all the other tissue at the same time. And then PARP inhibitors are a new type of medication that we're using for patients who have a certain type of genetic prostate cancer. So if you have certain genetic changes that we find, sometimes PARP inhibitors will also be like a smart bomb and go to those areas and kill those cancers. So I told you what I learned over the last 8 years in residency. I just told you in 40 minutes. So I hope you remember everything. I didn't go in great detail on everything, but I think you got the general gist. So thank you very much.
Thank you so much, Dr. Kim. That was really wonderful. I don't know about the rest of you, but isn't it amazing seeing the types of surgeries that Dr. Kim and his colleagues do? I'm always blown away when I see those. The technology has changed so much, even since I was in medical school.
Yeah, I think what I learned in residency, I probably don't do 80% of it, and everything that I do now is, I say 80% of it I had to learn on my own after.
Yeah. So thank you for keeping things moving for us. Do we have questions from our in-person audience? I see somebody in the back. And our online audience, don't forget to type into the chat if you have questions.
Does the chances of contracting prostate cancer changes as one ages, so that past a certain age, highly unlikely that you will get prostate cancer?
No. So as you get older, the risk of getting prostate cancer probably is higher. We stopped screening, in theory, in the 70s. And so just like colonoscopy, at a certain age they say, oh, you don't need to get a colonoscopy anymore. And at a certain age they say, you don't need to get a PSA anymore. But that's more based on the fact that prostate cancer is slow growing. So let's say you're 80 years old and you develop prostate cancer. The odds that you will die from old age instead of the cancer is very, very high. So that's kind of where the recommendation comes in, where we stop screening at a certain age, because we think that the prostate cancer will not grow quick enough for you to die from it. Does that answer your question?
Any other questions?
How is it possible for a patient to be negative PSAs over the years and then come up with grade 4 prostate cancer with mets to his bone and bladder.
So
I don't really know how the PSA would be negative over so many years.
Right.
You know.
So PSA is secreted by prostate cells in general. And if you have prostate cancer in general, your prostatic cell membrane is more leaky in a sense, and so more PSA is secreted into the bloodstream. However, sometimes when you have a very bad prostate cancer and it changes so much, it actually stops making PSA. And so once in a while, and this is not common, but once in a while you're going to see someone who doesn't have a very high PSA. They have a very high-grade cancer, a grade 5 or a Gleason 9 and 10 prostate cancer that's metastatic. And when you check it, sometimes you see that the prostate cancer is very undifferentiated. It actually changes. Sometimes it morphs into a neuroendocrine kind of cancer in addition. And it doesn't make as much PSA. So unfortunately for those patients, we find out usually very late. And it's difficult because that cancer happens so fast. Once you get that cancer, it grows at a very fast rate. So that's one of the explanations.
We have a question from the online audience. Is hormone therapy ever used in early stage prostate cancer?
Yes, it is. So I didn't go into the details of everything, but for example, let's say you're an older person and you have significant prostate cancer, but it's localized. You may not want a radical prostatectomy. You might not want radiation therapy. So sometimes you get a hormone shot, and then that'll put the cancer asleep, and then you can. You don't have to worry about the cancer growing. Now, hormonal therapy has its own problems because it gets rid of your testosterone. So you're like a man who's going to menopause. So whatever your wife's symptoms are for menopause, that's what you will have. So, you could low muscle mass, hot flashes, be grumpy, things like that. In addition, sometimes we supplement hormonal therapy with radiation. So we know that radiation works and that has good cancer control, but there are some patients who fail radiation, and we categorize these patients as intermediate risk, high risk, and stuff. And we found out that intermediate and high risk patients who have localized prostate cancer actually benefit from hormonal therapy for a short period of time with the radiation. So it makes the cancer more radiosensitive, so the radiation works better, the chances of being cured are better. So sometimes with localized prostate cancer, we will give hormonal therapy for a short period of time.
Thank you. Any other questions?
Thank you. Under what conditions would a stage 4 prostate cancer be treated initially with only immunotherapy?
Not very often. So in the past, you had to fail hormonal therapy, and then you would move on to another type of therapy, which was included immunotherapy. So Sipuleucel T or something like that. That's the traditional way of doing it. So it's not very common that you would go skip everything and you would go right to immunotherapy. But it does bring up an interesting point because, there's a lot of research going on, and it's looking at the immunotherapy just in general for all cancer cells. And there may be a time where we might develop a vaccine for prostate cancer. And so you can get a vaccine, that's immunotherapy. But we're not at that stage yet.
Thank you.
As men age, what is more likely, colorectal cancer or prostate cancer? Colon cancer or prostate cancer?
Prostate cancer.
Does an enlarged prostate actually lead to cancer or increase the likelihood of cancer?
No.
And no.
No. So they both happen with age. And so in that way, they're related. But just because you have a big prostate doesn't mean you have cancer. Just because you have cancer doesn't mean you have a big prostate. So other than that, they're not related.
If you have an enlarged prostate, does it continue to increase over time, or does it grow to a certain point and stop, or?
In many patients, it grows to a certain size and stops. But that's not true for everyone. That's not true for everyone.
There's one more question here. Is it true that drinking coffee can reduce the chance of getting prostate cancer? Drinking coffee.
I never heard that, but I drink a couple cups every day, so I might be okay.
I had never heard of that either.
What can help though is a low fatty meat diet, and then less processed sugar. So there are studies that less processed sugar and less fatty meats in your diet will lower your risk for prostate cancer. So they say a Mediterranean diet, more fish, more fruits, more vegetables, a Japanese diet also are better for you. And there's actually a very famous study from here, from University of Hawaii, and they looked at the Japanese who lived here, and they looked at the prevalence of prostate cancer in Issei versus all the way up to fifth generation Gonsei. And they found that every generation had a higher incidence of prostate cancer until you got to the fifth generation, where it's exactly as a Caucasian in the United States. And so there's something environmental, and they think it's diet.
Next week, we will be having a dietitian from Kaiser, Letitia Nagata, speaking to us. And actually, you're right, the Mediterranean diet is good for many things, including dementia, by the way. Yes. I don't see any more questions here.
The issue is a decision about radiology or surgery. Does the location of the lesions within the prostate help determine what procedure should be used? Because a lesion could be close to the wall or in the middle. I don't know the geography of the prostate very well, so that's why I'm asking that question. Radiology versus surgery.
Yes, that's one of the factors. So we look at a lot of things. We look at age, health. We look at their overall other symptoms. So like, let's say you have a lot of urinary symptoms. You have a lot of frequency, urgency. You have a very slow stream. Maybe radiation is not the best for you because it's going to get worse. So you may be cured of the cancer, but you may become a bladder cripple in that case. So we look at a lot of different things. So it's all individualized about what is the best way to go about treating it.
Okay. Any final questions? I see another one.
With manual examinations, why do they have men cough?
Well, that's more for the hernia.
Oh, I'm sorry.
That's more for your hernia. Yeah, Yes, so fatty meat diet, processed sugar, those are things that may increase your risk of getting prostate cancer.
Any more questions? I don't see any from the online audience. If not, please join. Oh, sorry, one more question.
What is the Gleason number and what causes the number to go up?
So Gleason is looking at grade of cancer, so the quality of your cancer. So when someone is diagnosed with cancer, one of the things that we want to figure out is how aggressive is the cancer. And when you look under the slides in pathology, we look at the architecture of the tissue, and that determines the grade. And if you have a high-grade cancer, a high Gleason score like 9 or 10, or a grade 5 cancer, it looks really, wild, and you can just see that this is a type of cancer that grows quickly. And then if you have a grade 1, it looks almost like a regular prostate cancer cell architecture, but it's a little bit different. So those are slow-growing cancers.
Okay, thank you all so much. And Dr. Kim, thank you so much for a wonderful presentation.